Hey, what's up, everybody? Welcome to our first podcast. This is me, Psych Life. Also, will be referred to as Juan. And today, here for our first guest, we have Dr. William Bridge from North Carolina, double board certified psychiatrist and in internal medicine. How you doing, Dr. Bridge?
Hey Juan, I'm doing well. Thanks so much for having me on the first podcast here. It's a good thing to be a part of.
No problem. No problem, William. I really appreciate you coming on and talking today about the topic, which is my favorite topic, and I practice every day, the art of psychology and mental health. But also, what makes this podcast very interesting is that you're a psychiatrist, and that's why I brought you on here today, so we can talk about the differences between psychology and psychiatry. And I thought today, William, was a good day as a first podcast to just even talk about what is psychology and what is psychiatry. You wouldn't believe how many people every day I get messages saying, "Oh, what's the difference? What should I study? What is psychology? I want to use it for self-development." And I tend not to reply to them, but I thought this format and this podcast would be a good way to reach people. What do you think, William? And thank you for being here.
Oh, thanks again. And it's really a similar setting for me. There's a lot of times where the two, psychology, psychiatry, are interchanged, and it's sometimes confusing because in a lot of ways they can be interchanged. But I think if it comes to your own productivity or your own well-being or mental health in general, it's important to know the difference, especially if you want to pursue a track of studying one or the other. And, maybe we'll touch on that a little bit as well. But I think, starting off here, I'll definitely answer a lot of questions. But I think in a perfect deal, it also generate more questions, So, I'm excited to talk about this interesting topic.
William or Dr. Bridge, do you mind which one I refer you to as?
Yeah, William is fine. Fine.
William, what makes this dynamic interesting is that when I went to a behavioral arts focused undergraduate degree, and you focused on biological psych, which is very interesting. So we're coming from the same field, but almost different avenues. And let's start off, if you don't mind, with the definition of psychology by the APA. The APA has a very simple, which is the APA is short for the American Psychological Association. They have a very simple way of defining psychology, which I find it to be very interesting because it's what I was taught 10 years ago, which is psychology is the study of the mind and behavior. About 10 years ago, I remember I had a professor who he changed that definition right there in the class. He put this definition on the board. He crossed out the mind and he said, psychology is the study of mental processes and behavior. I guess both of them can be used simultaneously, but the mind is different than the brain. So let's just focus for a second on that definition by the American Psychological Association. Do you agree that that definition sums up psychology, or do you believe psychology has a lot more to offer than that?
More so when I think about the word and what it means to me, I think definitely more so, along the lines of mental processing, and I think about it more of almost like the connection between neurons. You could see something flash up on the screen, a scene or a picture, and, entirely have a different thought and subsequent behavior than I would, and I think that's what's fascinating about psychology. I definitely think that it involves the brain, the mind, and the processes and how those two interact, and usually that interaction is in some form of behavior. But, as we'll probably touch on in other times, it's a lack thereof of behavior, which also has its different interpretations. So, in very interesting, world of study in psychology, and it's, riveting some of the things I expect us to talk about.
But I'm very glad that you brought up the part about a collection of neurons and the way that they're firing is how our behavior comes about, William. But the funny thing is that when we talk about neurons and the firing and the electrical impulses through the axons, that's more of the brain. And many psychology books I've read and professors didn't really define it. They try actually staying away from this type of topics, but I find them so interesting and so crucial in understanding, so people understand, is that the mind and brain, people tend to use them simultaneously, but those terms actually mean different. At least coming from my psychology world, the word mind actually means attitude, personality, way of being. There's so much more involved, almost on more of an unconscious level, to use that word. But the brain is more physiological. Does in psychiatry, we haven't even actually, we actually technically haven't even begun to define psychiatry, but it's very interesting that you mentioned that. Do the words brain and mind mean the same to you when talking about the definition of psychology by the APA?
I kind of think of, the brain is almost, the computer and printer system, and, the mind is kind of the, inner workings of what comes out at the end of the, processing system. So, I do think that they're different. But at the same time, they're related in the sense that you can't separate them, because to be honest, we have these patients that have different neurologic injuries and stuff, and it's proven that they really can't take it. Some of these higher functioning executive tasks. If you say, order these numbers on these cards from highest to lowest, that's an executive thought process that kind of takes place within the mind. And, with damage to the brain, you'll see that in given individuals that ability, that higher thinking is lost. So, I think that they are different, but we can never separate them at the same time, which is what's pretty fascinating about the two.
And people try to separate them all the time, and they want to focus on the mind and try to avoid the brain. And sometimes I think that's in large part too because the brain is so complex, and the mind is, I don't want to say when we talk about the mind it's not as complex, but it's a lot of things that's not causational. When we talk about the brain, it's more causational focus because we can actually measure it. We can actually measure what regions of the brain are operating at certain moments. We have the equipment for that because science has evolved. Now that we talked about psychology, and obviously I feel like that's my specialty as a mental health professional, but do you mind defining psychiatry for us, William?
Yeah, absolutely. So, kind of touching on some of the things that you'd said, I think that, when it comes to the medicine specialties, you had mentioned the APA. So the APA is basically the governing association that, contributes to this mass community of psychologists, psychiatrists, and they're involved with the evaluation and printing of these different DSMs, which is, of course, the diagnostic manual that we use in psychology and psychiatry. So, similar in that it, along the realm of neuroscience, psychiatry to me is kind of study of the brain and the abnormal psychology associated with the brain. So, if you have a given presentation, if they feel that a patient meets a given diagnostic criteria from that DSM, psychiatrists and psychologists alike are trained to the extent where they're able to diagnose. And I think where some of the variance in the two specialties is most evident is, psychology, the treatment along the realm of, research, along the realm of, cognitive behavioral therapy and kind of motivational interviewing, whereas psychiatry, training is done through a medical school. So you MD or DO degree, and you can prescribe medications if indicated for the diagnosis that you think a given patient has. You know, both along the neurosciences, but I would say that you know, one is more of the pharmacology forms of treatments, whereas the other is more of the psychotherapy mode of treatment.
And you hit that right on the spot, and I'm glad you brought that up. You said psychiatry is the study of the brain and the abnormal psychology of the brain. Just like we have here in psychology, the APA, which the main role of the APA, the American Psychological Association, which is where we got the term psychology from, guys. It's not like we just brought it up out of nowhere. The APA, the American Psychological Association, which the role it plays is to further psychology as a science. And the actual mission statement of the APA, I'm looking right at it, says the mission of the APA is to advance the creation, communication, and application of psychological knowledge to the benefit of society and improve people's lives. So they actually want to further psychology as a science to actually help people improve their lives, not only as an individual, but systematically. Where does the psychiatry field have an organization kind of like the APA?
Yeah, so last I had heard, the APA has roughly around 130,000 plus members. So it's an extensive association, and a lot of those, a strong majority, like myself, I'm a member of the APA. So there's a lot of psychiatrists involved there. I think the basis of that is that the common ground is the diagnostic manual, the DSM. Now, of course, in the 5th version, but it's a meeting, and they're based out of Washington, D.C., and a lot of the publications and newsletters, it's a reputable resource. So, there's a lot of psychologists and psychiatrists alike in there. But, I think what I would say is a similar type of, governing body of psychiatry is going to be the ABPN, and that's the Board of Psychiatry and Neurology. So that's kind of the sect that develops the board exams, determines what it takes to become board certified and recertified, and making sure you're staying up to date when it comes to evidence-based medicine, and the practice changes as they become clinically relevant. So have you had any experience with the APA or some of the content that they publish, and the meetings they organize, everything?
Well, the funny part about it, William, is that I was aware of the APPN. I wasn't aware, though, of what they offered as far as what did they represent, or what's their mission, or anything like that. But I am a part of 2 organizations, and one of them is the American Psychological Association, and I'm very happy to see that psychiatrists actually also are interested in what the APA is doing. And the other one I was into was the American Counseling Association, because to be clear, I am a counselor because I only have a master's. To be a psychologist, and I get this question all the time, so I'm glad I brought it up. To be a psychologist, you actually have to have either a PhD or a PsyD in psychology or in mental health counseling or something along those lines. Now, William, when it comes to both fields, we've talked, I've interviewed you before, and that's why I'm so glad. I guess you enjoyed our last interview because you were willing to come on. And when we talked about the difference between the brain and the mind. Now, there's so many theoretical orientations within psychology itself. And I'm not an expert in all of them. That's kind of absurd if anybody does claim to be an expert. But I am a psychotherapist, and I do try to have an eclectic approach. So I am somewhat knowledgeable in each one. When it comes to psychiatry, what type of theoretical orientation do you mostly use in the field?
I think that, a lot of the studies, and a lot of this, coming out of the New England Journal of Medicine and, a couple of others, JAMA is another big psychiatry journal. I mean, I think that a lot of the studies are done in such a way where they kind of compare, if you take, for example, a patient with major depressive disorder, this is just an example, and you look at a given group that is only treated with antidepressants. And then you take a group that is only treated with psychotherapy. And, the most common one, that is the best researched is, kind of like a cognitive behavioral therapy. And then, of course, they'll take a group that has both. You have a baseline antidepressants that's on board, as well as, however frequent they wanted the cognitive behavioral therapy or psychotherapy sessions. And then they look at them. And all the studies show us that, the both are better than one by themselves. So, I think where my training was from the therapy standpoint was more the CBT, which is the cognitive behavioral therapy. And then, of course, a lot of the emphasis psychiatry is medication based, but in terms of what you're more familiar with and what you see work in your patient population, what have you liked at this point in your career?
Well, for sure, one of the major things I learned in my master's program and the professors really got into detail about was utilizing an eclectic approach. And the research when it comes to therapy is kind of all over the place. And the one sure thing is that therapy, an individual that's going through the therapeutic process, does better in whatever the circumstances is, whether it be in substance abuse or extinction of maladaptive behaviors, than having no therapy. And the research also does show, like you touched upon, how having therapy as well as taking psychotropic medication at the same time is the best way to go about it, especially those that are meeting the symptoms for various mental illnesses. And I really love this conversation because I'm not sure if you know, William, but you knew I was in Asia. I'm not sure if you knew that I met with a couple representatives from the National Institute of Mental Health in Vietnam. And one of the things that shocked me was that they don't have any psychotherapists over there. And a matter of fact, the psychiatrist I met with, when I asked him what's his treatment modality, he says that the treatment modality that he used is just prescribing medication. Not that there was anything bad by it, but I was a little bit taken back. And when I asked him what his assessment tools were, he said that they had more of a systemic checklist assessment. And he wouldn't, I think he did mention the assessment, but I wasn't familiar with it. When it comes to psychiatry here, is it the same way, or do you guys actually provide psychotherapy along with the medication? And if you don't, do you refer them out?
Yeah, so that's a really interesting question, and what I prefer, and I always say that, just to touch on the point that you made about, it shows that if anybody's in any kind of therapy, generally they do better. I think in a perfect world, everyone would be able to talk with a psychiatrist or psychologist or therapist or somebody at the trained level of mental health, because there's nobody that will ever tell you that venting or sharing a grief situation with somebody that has training to respond and kind of elicit different thoughts about a given circumstance won't get better from doing that. There's a there's an undetermined power about, how well you'll feel just kind of, talking about things with somebody. So I think what kind of, from different, parts of the world, you'll see drastically different approaches to mental health. And that comes from different belief systems, different education, different training, and of course, different clinical practices in a different patient population. So, you have a lot of different cultural variants as well. So, I think that when it comes to my own clinical practice, if I get, for example, a new eval, let's take a 25-year-old with was referred by their primary care physician for uncontrolled anxiety. So that's really all the information that I have when the patient comes through the door. I usually get anywhere between 60 and 90 minutes for that initial evaluation. And I think that during the interview, it's my job to determine, is this a patient? Number one, is there a diagnosis here at all? Number two, if there is a diagnosis, what is the best and safest treatment? And if that treatment is medication, is there also a place, to have therapy? I think where psychiatry is going, and there's a good thing and a downside to it, is that a lot of the therapists and psychologists are becoming very, very trained in the different forms of psychotherapy, whereas the training on my end is, all of these new medications and these anxiolytics and these antidepressants. So my visit turns into, more, medication management. And that's only in the setting where these patients have a therapist. And I work in a setting in North Carolina where we share the same office. So if I think a patient would be good for therapy, I will refer, my evaluation to, the head therapist, and they will, then give their input about what therapist, if it would be the best for the patient. So it's great because if, the therapist is seeing the patient and their anxiety has gotten worse and they're, feeling like they're approaching hospitalization, then, he or she can message me or come to my office and we can get them an appointment. So see if we can prevent a hospitalization, and we can read each other's notes. So it's definitely it's a reciprocal therapy approach, and that's of course they'll get it in the therapy appointments, but also medication and trying to prevent any hospitalizations and allow patients to be at their best.
I'm so glad you brought that up, man, because I couldn't have said it any better, William. You said psychiatry focuses on medication management, while psychology focuses on all the different types of theoretical orientations involved. And both of them together, they work together, but the focus on the training is so different. And that's kind of the purpose of this podcast for the audience, is so that they know the actual differences between practicing and trying to get a degree or making psychology a career, whether it's at a master's level or a doctor's level, and psychiatry. In psychiatry, it's a lot more of the focus on the brain, while in psychology, it's a focus on the mind. Psychiatry focus on medication management, while psychology is focusing more on the theoretical orientations and how to put them into practice. And that's so essential, man, because we work together in this field, and that's very important to note. But here in America, because we're both practicing clinicians here in the United States, we're very lucky because they're evolving, and they evolved at a quicker rate than other countries, such as the one I went to in Vietnam. I mean, let's not even talk about Cambodia. Over there, they there's not many hospitals. I think there's like one or two per city, and that's that I went to the capital. There's another thing I wanted to touch on. I know we're running out of time here, William, as having you as our guest, but when it comes to diagnosis, I think when I first interviewed you a while back, I want to apologize for that because I came off a little bit aggressive when it came to that, and we're gonna have more with William, guys. Dr. Bridge, he's gonna be on a lot more with us. But one of the main things I wanted to touch on before you left, William, is that when it comes to diagnosis, there's a lot of now, I talked about what psychology was and what the APA defined it, but it seems to be missing a spiritual component. And now you have a lot of let's call them spiritual healers actually that's probably the proper term, like the Dalai Lama, the Sadhgurus over the world, who are mentors to me online, right? They take the field of psychology and psychiatry, and they kind of, I don't want to say push it to the side, but they say that a lot of the things we talk about is not real. And when they say that, they're talking about the diagnosis. And ladies and gentlemen, I want to just say something. The diagnosis, I get this all the time in my comments on Instagram or on YouTube saying, oh, my aunt has that. They have that diagnosis. Oh, you're talking about this symptom. That means that person has this diagnosis. That doesn't really work like that, right, William? These clinical terms are being used and thrown around in an incorrect way.
Yeah. I mean, just to kind of, add to some of what you're saying. So I think that, it's important that, of course, the media has a given spin on a lot of, some of these different diagnoses. And I very much so find that, the understanding of what the word bipolar means, there's a huge misconception about, what that actually means. So I think that, it's important to mention that they're really not definitions. There's elaborate diagnostic criteria. And a patient, it's not like they walk through the door and, in 2 minutes, what's one or the other. And I mentioned before, there's a lot of patients that get sent to me for initial evaluations. And, I find that at the end of the interview, there is no diagnosis. And I think it's important to realize is not everything needs a label or a diagnosis. And I think that, really in the fields where the spiritual leaders that don't, much give psychiatry all that much credit or don't feel that it's a true medical science, I would say that, a lot of the times are changing with that. We're seeing, CAT scans in the schizophrenic brain very different than the patients without any diagnosis of schizophrenia. We're seeing same thing in the antisocial, even the personality disorders, changes, structural changes in the brain. So it's becoming more of a biological medicine specialty, but it's different because it adds a degree of difficulty because in cardiology, we can check the enzymes and know when somebody is having a heart attack or an infarct. But when it comes to psychiatry, we don't have such lab tests, but it's not to say that that'll always be the case. I think, in my career, we'll have definitely a more laboratory and integrated approach to the medicine field. And, I'm interested to see what happens with it.
The four basic goals of psychology is to describe, explain, and predict and control behavior. Obviously, with the medication portion or medication management, which psychiatry focuses on, I don't want people to think that that's what the psychiatry field's all about. But the focus on the training becomes on the medication portion, right? Is the medications used almost to help control the behavior, to help limit the symptoms. And when you're talking about, when we're talking about mental illnesses, there's also a big misconception when it comes to the field of psychology and psychiatry, William, and that's that people think that because you're diagnosed with something, it's a chronic illness, or it's a chronic, they're diagnosed with, they meet the criteria, they meet the diagnostic criteria. It's not that they have this for the rest of their life. And that's something that, today I wanted to touch just on these components, but these are all components that I would love for you to talk about this with me again, because these are all components I think the audience needs to understand. And I've had actually people argue with me concerning this. I was diagnosed with depression. This is in me. And what I tell them is that you might meet the criteria for depression right now, but this isn't a lifelong thing. You have to figure out the different variables in your life and get them to work for you. It's not necessarily that you have this for the rest of your life. I'm not sure if you come across this type of thinking a lot, where you're practicing your profession. You're obviously a very knowledgeable individual, Dr. Bridge. So I'm not sure if you come across this a lot, but this is definitely something that needs to be addressed. And I hope that this podcast with both of us can help tackle some of these stigmas and some of these uninformed views of the population that is obviously being misused, man, like for real.
Yeah. And I definitely, of course, I hear a lot of the similar type of things on a daily basis. And, I think that, when people have different opinions and approaches to this, but when I'm seeing a patient, especially for the first time, I always have them in the best way possible describe what they felt when they were at the best state of their life. Whether that was, a few weeks into a new job that they really liked, when they were getting along with a significant other and they didn't have financial stress and they didn't have car issues and they didn't have, to deal with sick loved ones. And I kind of have them describe in detail the best time of their life. Because I think it's important to contrast that to how they're feeling on, the given day that they felt that they needed to seek help from a, physician or a mental health care professional. So when it comes to that, I think the comparison, it's not like they're not the same person. There's just a lot of events that have been added from, back when things were great to, today when things are not so great. And when it comes to, medications, my style is that I always give the patient a list of a few options. And of course, one of those options is always no medicine. And under each of the given bullet points, I, kind of lay out the risk and benefit or the pros and cons of each. And if they decide to move forward with a medicine, I think that it is important to emphasize that these medicines are not making them anything that they're not. That's number one. And number two is it's making it easier for them to act as they really are, and if it's a depression or an anxiety that has kind of created a filter between, how things are and how they see things to be, then, it's my job and, but then kind of remove that filter and, just do everything we can to keep them safe out of the hospital and kind of on a track that gets them back to that better place.
And it's funny that you mentioned that because I work with clients that they sometimes don't want the side effects of the medication. So what happens is I get clients that a lot of times that are referred from an inpatient residential facility that focuses primarily on substance abuse, secondarily behavioral issues. And what happens is that they'll come in after they obviously get discharged from the residential facility, the inpatient unit, after 3 to 5 months. They'll come and see me and they'll tell me, I want to try this outpatient program with you. I want to go all the way, but can we do it without medication? So when you're saying that you come up with a plan various plans. You say you don't just come up with one. That's how I know that you're a good clinician, is that you come up with various plans to see the opportunity, and then you go from there. And oftentimes I'll give them the opportunity to do it without the medication, despite their history, because at some point I want them to come off the medication. But if I tell the mom, I tell the parent, I tell them immediately, I'm very upfront. If it's not going to work, they're going to have to go back to the medication. But hey, Dr. Bridge or William, I really appreciate you coming on the platform, and I love collaborating with you. I want to collaborate with you more. And I think today was a pretty good first day, simple podcast, and people can start becoming aware about actual real mental health issues with two real professionals. And more than anything, actually learn about psychology and what it actually is at the same time, man, and psychiatry as well. I obviously have a lot more to learn from you when it comes to psychiatry. So I really appreciate you for doing this, okay?
Oh, well, thanks for having me on, and I appreciate the conversation. And it's always good to exchange ideas, and these conversations will lead to further things to talk about, and we'll get everybody's feedback in terms of whether there's something they wanted us to follow up on, or dive in a little bit deeper on, and we'll take it from there. But I appreciate your time, and thanks for having me on.
No, thanks, William. Okay, and thank you, the audience as well. I appreciate you guys as well for tuning in. So, till next time.